In males, hydrocele is a very common outcome. And this is an interesting story because sometimes it's very hard to get a male to tell you. Males are males all over the world. We're really stupid. We have this Y chromosome that it's missing essential genes that women have, okay? So in many parts of the world, you try and find out if a man has hydrocele, he doesn't want to tell you because having a larger scrotum than his buddies is macho, okay? But when it starts to get like this gentleman in Cairo that's on the left, then they start to get concerned. And then, of course, when it gets like this gentleman from Papua New Guinea on the right, then it is of serious concern. I can tell you another story later about trying to find out hydrocele that's kind of funny, if we have time. So the disease burden of lymphatic filariasis is as much, I think, a psychosocial and psychosexual and lost life opportunities. So in some families in India, if you have a daughter that looks like this, there are situations where they simply, it's like the old leper thing. They lock them in the back room and never let them out for people to see them because they're an embarrassment to the family. So this woman is not going to get married. She's not going to enjoy what most everybody else gets to enjoy. So that's what makes it tough. And these economic losses are just bloody guesses. We don't know. But billion is probably small, okay? So a while back, they started, and you've heard about this, as some of you have anyway, the global program to eliminate lymphatic filariasis. It was created in 1997. It's based on mass drug administration. We're not going to go into details of that, but basically what you do, you can't kill the adult parasites. You can go in and you can either give a drug combination of ivermectin and albendazole or diethylcarbamazine and albendazole. You'll recognize these drugs because they're the same thing that you use. Ivermectin is what's in HeartGuard for prevent your dog from getting heartworm. And it used to be you give them Filaribits on a daily thing, and that's diethylcarbamazine, DEC. So you give these, and you can give it once a year, and what it does is it knocks down these microfilariae that circulate in the blood for about a year. So what you do is interrupt transmission. So the whole strategy is to do this mass drug administration, not just with individuals that are infected, but in an infected village, you just treat everybody, okay? It's cheaper, it's easier. It takes a lot to try and determine who is infected. And then if you do this for 5 years in a row, theoretically you will have disrupted transmission to the point where all the adults then have died of old age and senescence or a combination of that along with the drugs, and so you'll have no more disease, and it sounds really good. The other part of the program, of course, was to alleviate suffering and disability, and most of that is done by taking care of your secondary infections. So there's been some really good progress in the control. Much of it having to do with the donations from pharmaceutical companies that makes it reasonable to do this, especially for ivermectin and albendazole. DEC still has to be purchased. There's a little problem there at times because you can't get enough. They're not making enough in some instances. The other thing that was important, you can imagine how hard it was to do detections in a village if the parasites that you had to detect are only available at night. So it used to be we'd have to go into a village at 10 o'clock at night, and then you do night bleedings until 2 or 3 in the morning to determine who's infected. So fortunately, they developed some very good antigen detection tests, and if anybody, I actually brought one of these little cards, if anybody wants to see what these are like, they're really simple. You can go into a village during the day, just get a drop of blood, put it on the filter, determine if they're antigen positive or negative. Then, if they're positive, they're the only people that you have to bleed at night to see if they actually are circulating microfilariae. So instead of bleeding, 1,000 people in a village, maybe you only have to bleed 200 people in a village. So quite a difference. And then, of course, there's been some effective management. So things are good, okay? So these are just some pictures showing this periodicity, and in Dr. Maggot, actually one of the guys that I work with, and probably Gary Weil works with more in Egypt, when we could work in Egypt, but we've been kind of kicked out of Egypt several years. It's a long story, okay? And then the development of the antigen detection test. So when you go into a village, and this gentleman talking is doing what we call a talk survey, okay? So I'll show you later, in Papua New Guinea there's lots of different languages, so there's a general language called Pidgin. So Taksavi means talk, T-O-K, but that's like T-A-L-K, and Savi is knowledge. So what we do when you go in, of course, is you have one of our colleagues from Papua New Guinea talk to the people and tell them exactly what we're doing and explain everything. And so this is John Bosco Kevin, who's doing that talk. And then you get consent, and you simply do your little blood prick and put it down, and then in 10 minutes you have your results. And the results will actually give us a good idea whether or not they do have microfilariae circulating in their blood. So this is a negative test with just a single line on the bottom. That's the antigen that everybody has in their blood, so that tells you that the kit is working. And then if you get that top line, the T line, and this is a nice dark one, okay, so this person probably has microfilariae circulating in the blood. So it's really simple and very nice and relatively cheap. The cleaning has made a huge difference in the pathology, and you can actually reverse many of the problems you have by simple elevation of the leg, like you do with any lymphedema, and then with cleansing. And this was really Garusa Dreyer in Brazil that came out with this. Wouldn't you say, Dan? She was like the most responsible. She's wonderful. So now, and when somebody has a leg like that, they clean it thoroughly if they know it's going to get better. I think you would all clean it thoroughly if you knew it was going to get better too. The other thing that you have to realize when you start to do a control program and you start to actually reduce the number of people in an area that have microfilariae circulating, to monitor that reduction to determine whether or not you've eliminated it, you have to sample more mosquitoes, because the probability of a mosquito picking up an infection goes down as the prevalence in a community goes down. So in order to determine whether or not you've actually reached your point of control, you have to collect more. So there are ways to mass collect, and this is CDC light trapping. The young lady in the middle is my doctoral student, this was in Upper Egypt near the Sudan border, but she's now in Papua New Guinea. So you use these CO2-baited CDC light traps and you can catch lots of mosquitoes. And what has been developed then is some molecular diagnostic techniques. You can't sit and dissect 10,000 mosquitoes that you might have to. So what you do is put them in pools of 50 and use a PCR methodology to find out if the mosquito has parasite DNA. We call this xenomonitoring. So by doing this, your mosquitoes are actually little hypodermic needles that are flying around the whole community, and they're sampling blood for you, and then you're testing them to see if any of them have microfilariae. Now, they were using this to determine transmission dynamics, how many mosquitoes had parasites that could be transmitted, but what we found out is that's totally false, because you could have a mosquito that would kill the parasite, but the residual DNA from the parasite basically persisted for the life of a mosquito. So it would turn up as a positive even though the mosquito didn't have anything but a dead parasite in it. But still, xenomonitoring is good, but you can't do it for transmission dynamics. There will have to be some new and more sensitive tests, probably based on RNA rather than DNA. So how does this work? Well, I've spent a lot of time working in Egypt, not on the control program, but on some transmission dynamics, but Gary Weil has. Okay, and you think of Egypt, you think of this. If any of you have been to Egypt, this is a good look at the pyramids. I mean, if you get on the other side, it's really a mess, okay? And that's not the mist in the morning, that's the smog from Cairo, okay? But they do have the Nile Delta, and they have, since they put the Aswan Dam in and have controlled the flooding and drying, they have a nice uniform wet environment that breeds all kinds of mosquitoes and breeds all kinds of snails if it doesn't get too polluted. The pollution is good for the mosquito that transmits lymphatic filariasis, however. It's a sewage-breeding mosquito. And this is a typical drainage ditch that runs around, on the upper left panel, runs around one of the villages. It's where all the sewage gets thrown, all the garbage gets thrown, and that's where the mosquitoes breed, okay? And it'll be filled with a mosquito called Culex pipiens. And this picture on the right is actually a latrine pit where all the pipes from the different villages go in, and you can drop a dipper down there and pull out mosquito larvae and pupae, okay? So this is Gary Weil, who's been as responsible for this elimination program, development of these antigen tests and all of this, from Washington University, has spent his life in Egypt. And this control program is working very well. It was until the time that Gary's program got kicked out of Egypt and my program got kicked out of Egypt, and we can't go back to Ain Shams anymore. So I'm not sure how the program is, because you don't always trust government agencies to tell you the truth about what a particular disease situation is in a country. It's not good karma to say you have a disease. It sounds much better to say you've eliminated it. But if you can't eliminate it from Egypt, you can't eliminate it from any place, because it's a bloody island in the middle of a desert, okay? So you have a very low prevalence of people infected in very few villages. You have a defined area that you can attack all of the people and do your massive drug therapy. It's not a big area. and you don't have any way for mosquitoes to fly in with infections unless they're going to cross the Mediterranean or fly all the way from the Sudan down the Nile, and that's not going to happen. So I think it'll work in Egypt if they have compliance as far as taking their drugs. So some major progresses, and there are also some major uncertainties, and these have been defined by Michael and others. We don't know if this strategy will interrupt transmission in all countries. In India, they don't think it will at all. They think they need mosquito control as well. One wonders if it's possible to define and quantify epidemiologically viable endpoints. You can't do control programs forever, but you sure can't stop them before you should stop them, or else you create the whole problem again, like what happened in India with malaria control. They had it down to a few thousand cases. Hard to fund a whole control program if you don't have a disease, so you put it into, the army to protect you from Pakistan, or at least to argue with Pakistan, and all of a sudden you have malaria again in India, worse than what it was before they did the control program. There's lots of different things, but what a vector biologist is dealing with is this thing here, because there are certain things associated with it that you have to know something about the vector to be able to do. In transmission with these, what we call heterogeneous parasites, or parasites that have more than one host, you have two major threshold entities, a vector to a human and a human to a vector. If you underrun either of these, you're going to stop the disease. But you have to sort of understand local situations with vector-host parasite associations to be able to get the right metrics to put into your mathematical models that tell you you can stop, or tell you you have to keep going. And these aren't trivial things. These are really difficult things to try and measure, because it takes a lot of work and a lot of effort. And most people, once they get down with the disease, they don't want to do that anymore. So this is very variable in different regions, because there seems to be really different dynamics, both in the way a disease presents itself in humans in different areas. For instance, in Egypt, you never see hydrocele in the leg, ever. I don't think Gary has ever seen it, but you see hydrocele. You don't see lymphedema, I'm sorry, on the legs. You see hydrocele. That's the manifestation you see. In other areas, you don't see hydrocele, you see mostly lymphedema. Some areas in India, that's all you see. So there's very big differences, and there's differences in the parasites and the mosquitoes. And this gives you a little idea of the diversity. So depending upon where you go in the world, you have different mosquito parasite systems operating. And I can tell you a Culex quinquefasciatus is very different than an Anopheles gambia, is very, very different from a Mansonia. And all of these things then do different things. So you have to almost look in different areas to see what you're going to do. And what's of interest to me here, and has always been, is these Anopheles gambiae, Anopheles punctulatus, and Fawadi transmitted Wuchereria bancrofti, because in these areas you also have malaria, and these are the same mosquito parasites that transmit malaria. So they're transmitting, in some cases, 5 different parasites, 4 different species of malaria and Wuchereria bancrofti. And nobody's really thought about that too much for a lot of reasons. So when we start to see how a parasite associates with a mosquito, we're talking about the mosquito in terms of vector competence. It's actually a component of vectorial capacity. Vectorial capacity is all these behavioral things. I mean, a mosquito could be highly competent to support a parasite, but it never feeds on a human. It isn't really going to be responsible for transmitting that disease. So these are kind of things. But vector competence, it really rests on sort of those genetic factors that determine whether a mosquito does or does not support the development of a parasite. Many of the mosquitoes that we know of, the 3,000 or so species in the world, don't transmit anything, okay? Some of them don't transmit anything because of an innate immune response. Now, it's not like the innate immune response we were listening to today, okay? But it's pretty good, okay? It recognizes foreignness, and it's what we do. The bottom 2 things, I'm not going to go into. I think probably Tony James, when he was here, probably talked about the bottom one a little bit. I would imagine quite a bit, okay? I'm going to talk a little bit about this innate immune response and resistance.